Testing, testing. Testing. 1, 2, 3. Testing. Oops. Can you hear this one? 1, 2, 3. There are 4. Can you hear this one? Testing mic 3. Can you hear microphone 3?
Yes. Great.
You can put it on your collar.
Oh, really? So today, this one, like up here.
Or I guess you're
I'll just look close.
yeah.
Now
Some
it works.
people talk with their hands.
I do. Yeah, that's. Like
Just
once.
press it once till it's and then don't press it again.
Got it. Okay.
Maybe you could think of
Shantae,
how do you see
can you hear?
people are on? Hey Dave, how do you see how many people are on the
Can you hear Shantae?
Hello? Okay. I think we can go ahead and just start. There's not going to be a ton of people in the audience. Residents are heading over from E13, and it's 7:34. Are you okay with what's?
Go ahead and do your case of the week.
That's true. That's true. Yeah, we can. I'm doing the cow. Okay, I'll just do the cow. All right. So, case of the week, I'll just go ahead and get started. We're talking about a 24-hour-old baby girl who was born at 40 weeks and 3 days with unknown prenatal care because her parents had recently immigrated from East Africa. She was born with Apgar's 8 and 7 and was otherwise a well baby who had normal energy level, was eating and sleeping normally, and just had skin lesions that were concerning to the NICU team. And so we were consulted to the IMC NICU a day after she was born. So on exam, we saw pink atrophic, in some areas somewhat cribiform plaques, and you can see with some overlying thin scale. These were not indurated. And then the same thing on her back, and you can see a little bit of xerosis on the rest of her trunk and surrounding skin. And then on one of her feet, she was missing a nail. It looked like a little erosion, but really it was just a non-indurated pink patch. And then you can see on her right hand, she has syndactyly with 2 of her fingers fused. Same sort of plaques on her arms with a lot of prominent skin lines. And then her face had really minor pink patches, a little bit of what looked like an abrasion on her chin, then the kind of xerotic prominent skin lines on around her eyes. And then her ears had the same pink patches, some hyperpigmentation. And then if you look in the further in, there's just a really pink patch. Again, it was not an erosion. And then she had some patchy alopecia with no erythema or atrophic plaques on her scalp. So based on her clinical exam, since she was well, torch infections or other infectious etiologies were not high on the differential, but they're the most acute, worrisome thing that we needed to rule out. So we recommended doing kind of a torch workup, and as soon as that was negative, we went to our other differentials that would have clinical appearance of aplasia cutis, like you saw in exam, and we did a biopsy of a couple of her lesions, and they came back as sponge derm with EOs, so not really conclusive. So we just went more off of physical exam, and I'll go through a few other clinical findings that she had that helped kind of seal the diagnosis of focal dermal hypoplasia syndrome, which is also known as Golt syndrome. So this is a rare X-linked autosomal dominant disorder that affects predominantly females. There are a few males who survive with mosaicism. There's over 120 mutations that have been found in the POR-CN gene that affects the Wnt pathway, which affects the development of lots of ectodermal, mesodermal tissues, including cutaneous, skeletal, ocular, oral, dental, and soft tissue. So, but because there's so many different mutations in mosaicism, there's a lot of variable phenotypes. And so the clinical diagnosis is based pretty loosely on just having 3 characteristic skin findings and 1 or more limb malformations. Some examples of the skin findings that you could see, which are usually present at birth, are the atrophic, sometimes cribiform plaques that we saw in our patient. You can see here hyperpigmented patches, and then pretty often you can also see linear arrays of these type of plaques and patches like you see in the 3rd picture on the screen. And if those are present, they're usually present on the lower limbs. And then when you biopsy these lesions, you should see some dermal attenuation with increased papillary dermal capillaries and adipocytes that are closer to the epidermis than they normally would be. And you can see in panel A and C, those adipocytes a little higher than they should be, and then increased capillaries in B, and this is a higher power of that same slide. And then sometimes you can get complete adipose replacement of the dermis. And we didn't have these findings in our patient, but these are kind of classic for Gold's biopsies. And then some skeletal defects. The most common is something called ectrodactyly, which is this picture of the hands on the screen. It's called a lot of things. Some people may know it as like a lobster claw. And then the other most common bony defect in the hands is syndactyly, and these are just examples of the different amounts of fusion you can have, or a patient can have. And then these types of bony malformations are present in 60 to 70% of patients. And then limb asymmetry with either an arm or one leg being shorter than the other is present in about 30% of patients. And then other findings, since I listed all those ways that this could present, other things you could find, some of which our patient had, is hair loss, nails that have longitudinal ridging, or they're just really small or completely missing, cleft lip or cleft palate, oral papillomas, few ocular findings like cataracts, and luckily our patient didn't or doesn't have that yet. So our patient came, so over the last year, so this was about a year ago, over the last year, she's had more workup to seal this diagnosis, including genetic testing. So this is a little screenshot of her genetic testing results, which showed the exact mutation she has in this PORCN gene. And they give like 6 pages of description of what to expect pathologically from this mutation. So we know that she has this for sure, but before knowing this, she also was found to have laryngomalacia, which is kind of like a soft, floppy larynx, and that caused her to have obstructive sleep apnea and breathe really loud at night. She required oxygen sometimes at night. It looks like she has a really minor limb discrepancy with one of her legs, but she's too young to stand straight in an x-ray, and so that's confirmed usually around 2 years of age. And then she had syndactyly, as you saw, and since then, around 11, 12 months, she's had operations with ENT and plastic surgery to correct her laryngomalacia and syndactyly. And then adults who have Goltz actually still have their skin lesions. They never, they don't naturally repair on their own. So they can actually be pretty disfiguring, you can imagine, and also sometimes symptomatic. And there's reports of them being pruritic or just easily traumatized because there's a lot of laxity, disfiguring because of the laxity and fat outpouching. And so this is an example of, this is just one case report of an adult with Goltz who wanted treatment for a lesion on her leg in her early 20s. And this team tried fractional laser with CO2. And this is a few photos from their study showing pre-treatment, where it's kind of hard to see, but they report that there's significant laxity here with fat outpouchings, and then the patient just reported a lot of pruritus. This was panel B is immediately after the first treatment, and they're 2 control biopsies. And I think they pointed out where the sutures are in the treatment area, but I can't see them. And then in panel C, it was 2 months after the first treatment. Panel D was 2 months after the second treatment. And then panel E is 5 months after the second treatment. And so you can see that there's some skin tightening, and the patient reported significant improvement in pruritus. And this is their path from that same mosaic area on the leg. So this is pre-treatment control. Pre-treatment, you see a lot of adipose tissue close to the epidermis and attenuation of the dermis. And then post-treatment control and post-treatment a mosaic area with filled in dermis and adipose not in sight. So yeah. Yes. That wasn't mentioned as a. Yeah, that's a good question. Sorry, the question was, so we're all going to try to repeat our questions for everyone who is online. The question was, in this photo pre-treatment, looks like there's a lot of. Oh, our patient. Oh, yeah. That wasn't, I have I agree so the question was that she looked hyperkeratotic and ichthyosiform. Do you mean in her atrophic lesions or in the skin around? Okay, on the skin around. Yeah, I agree. But it didn't feel like lichenified, even though it looked really xerotic. And I otherwise don't know why it didn't show up on path. Yeah, I mean, we did biopsy the atrophic lesion, so. And I think I actually thought I could also see some hyperkeratosis here, but I think that's just hyperpigmentation, which is more common classic finding. So anyways, maybe our patient will want this treatment when she's older. But for now, yeah, it's just an interesting rare case. That's it. Any other questions? Cool, we'll move on.
Oh, okay.
This one works. It's green. Don't press the button again.
No, I'm gonna push it a few more times.
The side.
Is it coming up? Stop. Thank you.
I'll just
To help. Awesome. All right, welcome everyone. So I have been asked to introduce our new residents to the program. Welcome to our new residents. I'm Aaron Seacrest. I'm leading Grand Rounds today. And I thought it was only fair because we have really interesting faculty and really interesting residents, as well as myself, that we should know some interesting things about each other. So I told the residents some of these things. My parents were full-on legitimate quintessential hippies. That is their actual wedding photo, and it is not faded. That is very yellow. It was horrifying. I spoke Vietnamese on a mission in Australia. So at one point, I was very fluent. My wife was a professional modern dancer. She was the only white dancer on a black dance company in Dallas. I lost 50% of our first down payment on our home trying to make money in the penny stocks. That was the first time I came close to divorce. I was investigated by CPS because my son slipped on his urine in a Rite Aid and got a spiral femur fracture, which you only get by abusing your child, or they slip on their urine in Rite Aid. And finally, I accidentally bought a car on eBay. Second time I came close to divorce. My wife was not happy about that. So I asked the residents to share some interesting facts about themselves. We have a new PGY3, that's Meredith somewhere, there she is. Meredith like me, loves audiobooks. She listened over 100 of them last year. This curse of the left leg is insane. Every female in her family has broken some part of their left leg. And then the other thing I thought interesting here was that she is a certified aerobics instructor. So if we need to add that to our program. Then we have Shaddai Goteman. Is that right? Goteman, okay. I just call your husband Barbu because it's easier. Shaddai told me an awesome thing. She said that when she was 4, she stood in front of a symphony during their rehearsal and pretended to conduct, and they really enjoyed that. And then she speaks enough Romanian to get herself into trouble. We have Lowell, who hails from California most recently, and he is an avid surfer, maybe, avid? He hasn't drowned, and he wants to transition to snowboarding. He used to study film in college and made movies with a Super 8 camera and some straight tape to splice it together. And then he did an internal medicine residency and worked as a faculty member or a hospitalist at the San Francisco VA before coming. We have Cece. Cece was a student here. I worked with her on a couple of projects, I think. The most interesting things here is that she loves snakes, which I hate. Not that you love snakes, but I hate snakes. She loves mowing the lawn, and I can so appreciate that. My wife thinks it's weird, but I can just go into myself, and so Cece relates to that. And then she's never had a bloody nose in her life. And then Nicole, I am so sorry. I didn't hear anything from Nicole, but she is super interesting as well. Do you want to tell me anything interesting?
Oh gosh. Oh, for my fun fact, I had said that I'm obsessed with plants, and we lived in a pretty small house in Charleston, South Carolina, where I'm from. And I had, I think, over 50 to 60. So then moving here, obviously, I had to gift them to everybody. But my husband is now placed an all green things embargo here. So technically, I'm not allowed to bring green things into the house, but he's out of town. So yesterday, I went to Trader Joe's. And there's like 3 plants already, so.
All right, and then I'm going to turn the time over to Keith to introduce our new Mose Fellow, and then we will turn the time over to Jamie Zussman, who hails from UCLA and has been with us for several years now and is one of our faculty who does dermatopathology, and she's going to tell us how awesome it is.
And one interesting thing about Jamie?
No, I have no idea. I don't know.
I don't want to share.
And put her on the spot. So I just want to introduce our new Mose Fellow, Allison Theed is over here. I didn't have the photo. I didn't know what was going on. Sorry, I didn't get the interesting facts and things like that. But I'll try to come up with something or put her on the spot like poor Nicole. Allie is most recently from UCSF. She did her residency there, completed her residency, did her undergrad at Michigan and then med school at IU. So she's got some really good, Midwestern sensibilities. So I think she's going to fit in just fine with us. The only interesting fact I know so far about you is that you were a U of M cheerleader, if I remember correctly from my interview, right? Is there anything you want to add to that today? Okay. So Allie lived in 8 different states before the age of 15, which is a pretty impressive fact. So that just tells me you're very good at assimilation and making friends. So I'm sure you'll do awesome here. We are very happy to have you. It's been a great first week so far. And so just get to know everybody. It's a huge group. There's 12 residents, there's 50 plus faculty, so we're gonna have a get together in a couple of weeks, but just try to get to know each other. And I think, Jenny, we're gonna have to talk about the new grand rounds format since we're all kind of back. It seemed like we were disjointed this morning, so we'll have to actually put some times down, I think, about like patient viewing, when we come back to the grand rounds room, et cetera. It's kind of weird being back, isn't it? Having everybody in one room together and discussing patients again, and yeah, it's great, yeah, so. Okay, I'm gonna hand it over to Jamie for dermatopathology for the win. I'm excited about this. I don't know about you guys.
Hello, everybody. I feel so very lucky that I don't have to talk to a computer today. This is just like very wonderful to have faces to speak to, because that was not fun lecturing to myself. So I chose this title when I needed to come up with a lecture quickly and I didn't know what I was going to talk about. And I thought it was a pretty generic title and I could go kind of any direction. And it turns out it's a little bit misleading because it's not necessarily so much about how dermatopathology is awesome and we're going to take care of all of the troubles in diagnosing patients. It turns out the lecture is more about how we can all work together as a team to help make dermatopathology come in for the win. And how there's so many necessary elements that go into it to get this correct diagnosis. So I have no conflicts of interest, except I was thinking, like, I love it when you guys send us cases, so please do lots of biopsies because we love getting a lot of cases. So I put this picture in here because, I was thinking about like what my perfect day at work is. Like if I'm coming to work and I'm coming in to read slides, my dream day is if I come in and like every case I look at, this has never happened by the way, but if every case I looked at, the clinician didn't know what was going on. And then I looked at the slide and came up with the answer for him and like got the diagnosis for the patient. And, I was like the sole hero that figured everything out. That would be my dream day. And I think, that has happened that happens like 3 times a year that you get 1 case a day. So that's just in reality, not how things work in dermatopathology. I think as a dermatopathologist, we all kind of look at it more like this. There's so many people that go into making a correct diagnosis on a slide. So it really is kind of a team experience to get there. So I put in this slide just to kind of start to think about all the different things that have to happen to reach that correct diagnosis on a slide. So kind of starting at the bottom, the first thing, of course, the patient has to schedule an appointment, which can sometimes actually be really hard, but we're not really going to go into that today. And then there has to be a clinician that identifies that there's an issue and they need to classify it further. Then they have to perform the biopsy. Then the lab has to receive and process the specimen, and then the dermatopathologist gets the slide, and hopefully we give you the correct diagnosis if we're having a good day. And then maybe we can, get this correct diagnosis and get the goal that we all want. Our victory is getting this patient the proper care that they deserve. But there are a lot of places where there could be little mishaps that we have to think about. So I just kind of, on this slide, this is part of the team. And I know I left something off. So please, if you guys can think of a component that I left off, feel free to shout it out because I don't want to hurt anyone's feelings, but just thinking about all of the different people that have to take part in getting our slides made and helping these patients. We have couriers that collect slides from clinics. We have histotechs that cut the tissue. There's our dermatopathology staff that accessions all of our tissue. There's the clinician performing the biopsy, the schedulers making the appointments, the dermatopathologist interpreting the slides, medical assistants putting specimens into bottles, labeling the bottles, getting them all set up to go to the lab. And then there's the grocers. The grocers are cutting the tissue, and then the histotechs are kind of like slicing it and putting it on the slides. But at each of these steps, there's something that can go wrong. People make mistakes. And I think that that's something that we tend to forget when you just think, oh, the patient comes in, you do a biopsy, you get the answer. But it can be a little bit more complicated than that. So today, I just kind of want to review the necessary components that lead to an accurate pathologic diagnosis. You know, we need to work as a team to make this happen. I'm going to go over some examples of hurdles that can be faced during pathologic assessment from the dermatopathologist, you know, perspective, but also at different steps along the way. And then just talk about things that we can do to just optimize patient care and reaching those correct diagnoses. So I'm going to kind of ignore these first two components, the patient scheduling and the clinician identifying pathology, because that will be addressed elsewhere during our practice, but that's not what I'm going to focus on today. So first we want to talk about biopsies being performed, because a lot of the time I think from the patient's perspective, they think, oh, you're going to do a biopsy, you do the biopsy, you get the answer, right? And like the one answer that gets spit out, it's the right answer, and there's no wishy-washy anything, but it's more complicated than that. So say we get a patient that comes in as a clinician and we decide we want to do a biopsy. Before the biopsy takes place, there's lots of things that should happen that might not always happen before we perform that biopsy. So, you know, we have to think about what kind of biopsy is the most appropriate type of biopsy to do. Are you going to do a shave, a punch, incisional, excisional? You got to think about the location of the biopsy, whether you want to go, you know, right in the middle of what you're looking at, or do you want to go to the side of it? You have to think about if the area has been treated with any medications prior to coming in. Are there secondary changes that are going to screw up your pathology results? And you also have to think about sampling error. So if you want to sample a really complicated rash, you might want to get multiple biopsies just so that you don't make the mistake of, you know, getting that bug bite that just happens to be in there. So when we think about doing a biopsy, I would say the most important thing to do when you're starting off is to look at either the neoplasm or the rash and formulate a differential diagnosis, because without having an accurate differential diagnosis, you are not going to be able to perform the correct type of biopsy. So first you come up with your differential diagnosis, and then the other key to knowing what type of biopsy to perform is knowing the histopathologic features of all of the components in your differential diagnosis. So you need to think about, if I am going to sample a certain rash, where is that rash located? Is it located primarily in the epidermis? Do we have pointers? Are there pointers? I don't know. So is the rash located, you know, up in the epidermis? Do we need a superficial biopsy? Is it a dermal process? Is it a subcutaneous process? You need to know where those processes are located to be able to perform the correct type of biopsy. And this slide just kind of gives a representation of how deep we tend to go with different types of biopsies. Thank you. Okay. So I just thought we could do a little exercise here. And maybe from the crowd, I would love a differential diagnosis here. Blue nevus, DF, mastocytoma, that's a good thought. So these processes that you guys are mentioning, where is the pathology located in the anatomy? In the dermis, right? So what type of biopsy do you think would be appropriate in this situation? A punch, because with a shave biopsy, you're not going to get that deep dermis, right? So we come back here and we know, because dermatofibromas, mastocytomas, blue nevi, they're located in the dermis. Are you being serious? Well, I would say, so this is, you know, this is kind of where we run into, and this is why I kind of wanted to give this lecture, because all of us dermatopathologists are also practicing clinicians. So we think about these things and we know these things, and then we get to clinic and sometimes you're like, I'm in a hurry, I want to be done with it, let's just go. And well, I guess we don't know how big it was. We have no idea how big those were. So So, and then I would say a shave biopsy would be fine. It is a dermal process, but if you get a shave biopsy and you have like almost no dermis, are you going to be able to get your answer, right? So I would say most of the time, and this is a dermatofibroma.
Good shave biopsy.
Right. A good shave biopsy. So there's different types of shave biopsies, right? So there's shave biopsies that, there's shallow shave biopsies that don't bleed much. And then there's scoop shave biopsies where you actually get to see some of the dermis. So you know if you just have pinpoint bleeding when you do your shave biopsy, you're getting very minimal dermis. And if you're wanting to sample a dermal process, you're not going to get it, right? So I would say most commonly you are correct. Like for dermatofibromas, we do get shave biopsies because a lot of the time there's a basal cell in the differential diagnosis, which in this case, in this picture, you know, we have enough. We have the classic epidermal changes and we have the increased fibrohistiocytic cells within the superficial dermis. Here we have enough to make the diagnosis. I would say quite frequently we don't, and we can say, this is what we think it is. Like there's hints around it. But you might get a little bit more of a wishy-washy answer than if you went in and actually sampled the whole dermis, in which case we can just be definitive, done with it, no questions asked. So just thinking about where that pathology lies. I don't know, what do you think, Keith?
I think it's a decision of.
Right.
So I think like that's removing the lesion. We can remove it, like I agree, this is the way to go.
But I would argue that if you think that's a blue nevus, I don't know why you would want to transect it so you can't see the whole thing. I don't know. In my eyes, that makes me uncomfortable as a pathologist, like when I have a part of a nevus. I don't know. What do you guys think? I know, that's why I'm like pulling the crowd. Yeah. Right. So I think what we're hearing from the crowd, for those of you that are listening remotely and can't hear, is that if you're just looking for a diagnosis, if you're not looking to remove it, a lot of the times you can get a diagnosis with shave biopsies, but you have to do a deep enough shave. Does that sound like the consensus? And if you want any chance of removing it, you would probably want to go deeper. And if you want like 100% definitive.
Yeah, I think our main point is like when you're
Right.
different shapes.
Every shave biopsy is not the same, is what Keith said.
What you're
Right.
it's not like as easy as the like there's different kinds of shapes, there's different kinds of punches.
And Keith is making the point that there's different kinds of shaves and different kinds of punches, and you're absolutely right. So taking that into consideration. So this is just another case that I would love to get a differential on and hear how the team would like to sample this. Contact dermatitis, bullous pemphigoid, bullous impetigo. Those are my top three when I look at this. So where are those processes located? In the superficial, right? More in the epidermis. And there can be superficial dermal changes in all of those, but it's mainly an epidermal process. So when we come up with that differential, and there's not really much that is included in that differential that would be deep down in the dermis, I think a shave biopsy would be really appropriate here. I think sometimes when we see, you know, these blistering lesions, a consideration that I always think about is that if you were to do a punch right in the middle of one of these bullets, it's really easy to shear off that superficial epidermis. So sometimes like a broad shave is nicer because you get more adherence of that epidermis. And this is just a representation about how this would be appropriate for a shave biopsy because it's a more superficial process. So just a little just prior to sampling, anything, formulate differential diagnosis, and know the anatomic level of the pathology for all of the considerations in your differential, and then choose a biopsy technique that will encompass all of those necessary components, because without doing that, you might not get your diagnosis. And then just like another thing to think about when you are doing sampling, and this goes into, you know, a shave is not a shave is not a shave. If you do a shave that's 2 millimeters thick on the eyelid, you're going to get to a whole different anatomic level than if you're sitting here on a foot or an acral surface. And I just put in a picture here of, maybe you can see, oh no, there's no arrow. Or wait, no, there is an arrow. So I put in a picture here, you know, an eyelid skin might come to about here through that stratum corneum. So if you did the same shave on the eyelid, you would not even reach the epidermis here on an acral surface. So just a little pearl for acral surfaces. If you're doing a shave biopsy, go way deeper than you think you need to go. If you think you're going deep enough, you are not going deep enough, is what we see. So, and this is just like, I put this picture in because this is how I feel a lot of days when I get these acral biopsies and it's like, rule out melanoma, and I have this stratum corneum to look at. And it just makes me feel so sad because we want to give you an answer. Like, that's just what we want to do, and we can't.
Yeah, sure. Go ahead. Here's Spencer.
If you were doing a BP rule out, would you shave your DIF also?
Yeah, yes. I think that it's nice to. I think that whatever you can do to get adherence of that upper layer is helpful. Yeah, and I guess if it's perilesional, it might not be as likely to shear off, but I think that they're fine with shave biopsies because you think about where the pathology is that they're looking for. And I'm sorry, the question was if you are doing a biopsy for DIF, what type of biopsy would you do? Yeah, so if you are biopsying an acral surface, go deeper than you think you need to go. And then just another pearl to think about when you are sampling rashes is that you want to look for active inflammation. I think something that we see quite frequently, I put this example up here as a scalp biopsy. Scalp biopsies are really tricky, knowing where to sample an alopecia, but I think looking for areas of active inflammation in any process is going to help get you closer towards the answer. So I got a biopsy from this patient the other day. And I looked at the biopsy and there really wasn't much going on. There was like maybe some hair drop out, and I looked at the picture and it might be hard to appreciate here. It might not be projecting that well. And I'm like, well, this area is not red. Can you see my pointer? Where they circled, it's not red, but over here it looks so red. So I'm like, I want the red. I want the hyperkeratosis because that's where I'm going to see the inflammation. So go where you see that like redness, purplish, crusting inflammation. This is an inflammatory process, is not one of the ones where you want to go to the periphery, right? Thinking about where you want to biopsy. And then another pearl is just to avoid areas with secondary changes, if at all possible. If you have a patient coming in and you're like, these are neurotic excoriations and they're demanding a biopsy, obviously you're probably going to have a biopsy with secondary changes. But if you think that there's real pathology going on, I would say it's quite frequent that we see biopsies come in and we have this ulcer, and there's an ulcer and we know it was probably scratched, but then that can make it really tricky to see if there's background inflammation. Sometimes we get lucky and sometimes there's stuff deep and there's eosinophils. But then so I got this biopsy the other day and then I look at the picture and I see that they got one of these little ulcers, and then around it is all this redness that's not ulcerated. So in my mind, I'm like, oh, I want that redness, right? I want the redness. I don't want the ulcer, because I think that might give me a better idea of what the primary pathology is without any secondary changes, kind of messing things up and distracting us. Any questions? And then remembering that when you are going to do a biopsy, that diagnosis can be hindered by prior therapy. So very, very often we have patients come in who have used Effudex, And they're like, is my cancer still there? And they're say, oh yeah, I stopped using it last night. Is my cancer still there? And of course they have this big like crust on their face, and we have no idea what's going on because they're so inflamed from their FUDEX. It's not common that we get biopsies of that. This is an example of a biopsy for a patient that was still actively using FUDEX, and the question is it cancer or not? And I would say these FUDEX biopsies could be really tricky because it's impetiginized, it's eroded, there's tons of atypia, but I think at this point with active FUDEX therapy, it can be like super hard to tell whether there's reactive changes or whether it's real atypia. And so in my practice, what I've taken to doing if a patient's using FUDEX, and if it's all possible, if they're not from 300 miles away, which sometimes happens around here, and that might make you change your decision making. I just say, you know what, we're going to wait like 3 to 4 weeks and we're going to see what it looks like and we'll biopsy it then, because I know the pathology, if we biopsy it, is going to look like this, and we're going to come into this dilemma, like, is it real, is it not? And so taking into consideration prior therapy, whether it's FUDEX or prior steroid therapy, prior antifungal therapy, which can also dampen and change findings.
Can I have one comment, Jamie?
Yes.
This is great. I think we should do like a DermPath series like this. This is fantastic. The FUDEX and like steroid thing, just tell us, like 50% of the time, it's like not on the report, like current FUDEX or prior FUDEX therapy. And then we have to like go digging in Epic and try to figure out like what's happening. But like, it's a difference between like a 1 minute look and sign out and a 15-minute look and sign out. So you can really help us out and save a lot of back end time if you just tell us what's going on. Like you can put as much as you want in that differential diagnosis. It's not limited. You can do like a page if you want there, and it's great.
And so this is just kind of like a summary of what I've been talking about. So pearls for sampling rashes, avoid partially treated eruptions if you can. I mean, this is my practice. If a patient's like, I've been using steroids on this for the past 2 weeks, I say, well, sorry, I know this biopsy is not going to be helpful. You need to come back. And I don't even do biopsies in those situations. Or if I think something's fungus and a patient's been using antifungals on it for 2 weeks, I'm like, you know what, we need a little bit of a washout period. You could do the biopsy, but it might not be that helpful. And then they're going to come in and you're going to do a second biopsy. So sometimes I'll leave it up to the patient based on their situation, but most often I do try to avoid biopsying those partially treated rashes. And then kind of some potential pitfalls we talked about with biopsy site selection. I would say it's not infrequent when you're sampling a rash that we might see a lesion of folliculitis that's accidentally sampled, or an inflamed keratosis, because when somebody has a rash, everything just looks inflamed and crusty and red. So you get these kind of sampling errors of things that are not part of the rash. So if you can take multiple biopsies, that can be really helpful and give you a better shot at actually getting to your answer. And then thinking about the age of the lesions that you're sampling. If you're sampling a blistering eruption, trying to find a new blister, you're going to get a lot more information than like an old crusted healing blister where, the level of vesiculation might not be as evident. Or if you're sampling psoriasis, it's actually better to go the opposite direction and try to find like the oldest, most well-developed lesion. Because if you find an incipient lesion there, the findings might not have developed enough to actually reach that diagnosis. So it's really key when you come up with your differential diagnosis to think, do I want an old lesion? Do I want a new lesion? Do I want to go right in the middle? Do I want to go on the side? And then just thinking about it, we love big punch biopsies. So the bigger the better, especially if you're thinking about something that might need to be worked up with stains. Like if you're thinking about a lymphoma or something like that, please, like 5-6 millimeter. I think Dave likes 6 millimeters, right? The bigger the better.
For example, there was a recent case that Grace saw at Huntsman, and she took, the clinical morphology was not that striking, but the differential diagnosis was broad and included hematolymphoid neoplasms. And I think, Grace, you took 3 6-millimeter punches, is that right? That's exactly, what we would want, because it turns out that if you just did one punch biopsy, or if you did a couple of 4s, would have had to ask the hospital team to go back, because we were able to, confirm a very rare diagnosis involving the skin, and a very complex one to try to identify, requiring numerous stains. So Jamie, I think, your point is well taken. Even for breast cancer, if you need to do immunostains or, for prognostic markers and potentially sequencing for therapeutic targets, just about any neoplasm I can think about, I would recommend us starting, the thought process in my mind is starting with a 6 punch, and, you scale down to a 5 if you need to. But if you're starting with a 4 for something that you're going to need a lot of studies on, then we have a pretty high risk of running out of tissue.
Yeah, throw away the 3 millimeters, please. And I think I've noticed that the residents have gotten really good at doing these big punches. So I think we appreciate it. We really do appreciate it. And then this is just something I think before I did my dermatopathology fellowship, I really had no understanding of how tissue was kind of embedded and grossed and sectioned. And, when I did this biopsy, what happened to it? So I just wanted to show a couple pictures to give people a little bit of a better understanding of what can happen when we section tissue. We get a lot of biopsies that come in that say, we did this biopsy and then we did an EDNC and electrodesiccation and curettage. Was treatment sufficient? And so this is a question I always have a really hard time with personally, because most of the time when we get that question, I would say the cancer is transected. So I'm like, I don't know what's going on underneath. Like, I can guess, but it's a total guess. And then even when it looks like the cancer has been taken out, this is a representation of a biopsy that was done. Slide A shows like the initial section was cut. Slide A and slide B. These are the initial sections. Oops. And then slide C and D were deeper levels. So if the pathologist had made the call on these initial sections, they would have said, yep, the cancer's out. These are shaved biopsies. The margins are clear. You don't have to do anything else. But in this study that they did, they went through and they cut through the block, and they found that actually in a quarter of shaved specimens, if the initial cancer looked clear on those first cuts, in a quarter of the specimens, they could go through and find that it actually went to the margins and deeper levels. So just when you think about, like, is it clear? And you're asking that question, think about your intent with the sampling. Was your intent to really get around it? And you're like pretty darn sure you got around it. I would say in that situation, if the biopsy says clear, you can feel a little bit better. But if your intent was not to get around it, I would be a little suspicious and wary and know that it might not actually be clear. And this is just like another way of thinking about how sometimes we might not be able to assess margins with a shave biopsy. So these lines here are kind of the cuts that would be taken and put on the slide. Those are like the 2 little sections that are taken. So you can see if these are the 2 cuts that are put on the slide, it would look like the margins are clear because that's what we have. But if they were to take it and section it the other way and make the lines this way, we would be able to see that, oh no, the margins are not clear. So sometimes when we, you do shave biopsies of moles and we say, well, we don't really know if the margins are clear. This is why, because it all depends on how the tissue was sectioned, and a shave biopsy is just not made to be able to assess margins. And this is, I don't know why I put this in, because it's just kind of, it makes me uncomfortable, but we all know that when we do elliptical excisions, there's not 100% cure rate. And this is just kind of demonstrating why that is, why there's this kind of like 5% failure rate on elliptical excisions for margin clearance. It's because with elliptical excisions as well, we are not looking at 100% of the tissue. We're looking at a very small percentage of the tissue. And again, this is something as a dermatologist, I wasn't always thinking about, but where these sections are taken, it looks clear. But if they had taken a section right through here, the B, they would have seen that the cancer actually did go to the margin. So I think that's just a good thing for clinicians to be aware of. Okay, so now we're going to move on a little bit. I think I got to move a little quicker. Move on a little bit to the lab receiving and processing specimens and think a little bit about what can happen there. And so there are so many steps where something can go wrong with tissue once the biopsy is performed. And we see all of these all the time. And it's just like amazing to me that they don't happen more with all of the steps that have to be taken to correctly process tissue. So some things that we see are that specimens get switched in clinic. You do 3 biopsies, you put one in one bottle, one in the other bottle, and oops, they end up in the wrong bottles. So something that I've instituted in my clinic is like the labels are on all the bottles before the tissue goes in them, right? And before I put anything in a bottle, my MA holds it up and I see the site and then I put it in and then I close the bottle. Sometimes the specimen doesn't make it into the formalin container. So I should have said the next step in that is I look in and I make sure the tissue is in the formalin and not on the side and not on the roof. And then you close the bottle. Something that can also happen is that, yeah, what? Oh yeah, shaking it, getting it in the formalin is really good. It's great. Another consideration I think we don't think about a lot is making sure that you have enough formalin for your tissue. So really you should have about 15 volume equivalents for each volume of tissue. So with little biopsies, this isn't going to make a difference, but this comes into play when you're doing your big excisions. Make sure you're asking for those big specimen bottles. You need a lot of formalin to properly fix that tissue so that we can arrive at that correct diagnosis. Sometimes the specimen gets lost before it makes it to the lab. Sometimes if you do too small of a biopsy, it might not survive processing. We've seen cases where specimen slides can get improperly labeled. So this is just an example here. This was one specimen and a portion of it, they came in and the grocers noted that a portion of it was closed in under the biopsy lid and crushed. So this is an example of crush artifact from a biopsy lid. So just again, making sure it's in the formalin, making sure it's not on the lid. And this is something that can also happen if you take your forceps and you're doing a punch biopsy and you go smash, right? You can still see that kind of same crush artifact. So just keeping that in mind. And this is something that me and Keith went through last week that I just wanted to share. So I had a patient who came in and she had this little spot and she said it was growing. So I did a shave biopsy in clinic and then I got my path report back. It said residual superficial basal cell and scar, both excised. And I was like, that doesn't make any sense, right? Like what's going on here? So it was an unexpected result. So I wanted to find out what was happening. So I called Keith and I said, hey, let's pull these slides. Did something happen? Did something get switched? And so he pulled the slide. And this is the slide that comes out. And this looks like a classic excision slide. This does not look like a shave biopsy. So we're like, there is an obvious error here, right? So we went through and we did some digging. And it turns out that there was a labeling error made by the lab on the slides. The specimens ending in 8.5 and 5.8 were switched. And so we found the 5.8 or the 8.5 and we compared them and we looked at the tissue blocked and we looked at the size of the tissue. And then we saw that this shave biopsy went along with my patient and it fit clinically and it was a lichenoid keratosis. So we reached the correct result, but it did take it just took somebody to notice and a little bit of digging. So mistakes happen. We can correct them if we're paying attention.
Yeah, so the interesting thing about that is I missed Jamie's case, but the other case was Luke Johnson's. And there was something about it in the differential diagnosis. It just didn't make any sense. So I basically just made a note check Epic later, right? Because sometimes I'll use an Epic run, I'll just go through Epic and do 10 cases while I'm in Epic. So I caught it on the other end, but I didn't catch Jamie's case. So, so it's all about when in the processes, right? People's got it, the system check. So Jamie checked it on her end and found it, and I had a separate check on my end, so it probably would have been found on the opposite side.
Yeah.
Anyway, more information in the differential diagnosis is better. So, okay.
Yeah. Okay. And so then I didn't go into detail about everything that can happen in the lab, but you get the gist of it. Stuff can go wrong. So if something doesn't make sense in your report, question. And then kind of the next step in the process is having a dermatopathologist that will provide you with an accurate interpretation of what they receive. So I'm going to embarrass myself here. So I got a biopsy from this patient. And the biopsy came in rule out bullous pemphigoid. And so I looked at the picture. I was like, oh yeah, that looks like bullous pemphigoid. And I looked at the path. I was like, huh, that looks like pemphigus. But the clinician thought it was bullous pemphigoid. And so I don't know what I was thinking. I was like, I convinced myself that there was re-epithelialization, and I signed it out as like subepidermal bulla consistent with bullous pemphigoid, and I kind of moved on, and there was like this beautiful eosinophilic spongiosis. And then I get a call from a colleague from Jay-Z who said, you know what, the DIF and the IIF are consistent with pemphigus. Can you like review the path? And I go back to the path and I'm like, well, yeah, it's actually really classic for pemphigus. And I was just embarrassed. But I had this clinician that was telling me it was pemphigoid, and I saw the picture and I saw these two tense bulla. And so I think it was a combination of confirmation bias and anchoring bias that led me to just put something I knew was wrong. Well, I didn't know it was wrong. I was like, okay, that works. You know, that'll work in this situation. I put it in the pathology report. But luckily, you know, I felt like a failure that day, of course. But luckily, I had a colleague that was not afraid to kind of speak up and say, hey, pull this path and review it. And could you have been wrong? So we corrected the report, we got the patient the right answer, and to me, that's a victory, right? Like if I'm wrong, I want to know it, and I want somebody to tell me so that we can get the right answer for a patient. And then kind of this is the last case I'll go over, but this was a patient that was recently hospitalized who had this rapidly progressive kind of vesicular erosive rash covering most of his body. It was a really scary presentation, and he was just progressing so quickly and nobody knew what was going on. We did like biopsy after biopsy. I think we had 3 separate biopsies of this patient, and they all looked similar. There was like this crazy papillary dermal edema.
Dr. Waller and I did 8 biopsies.
Oh, 8 biopsies, excuse me. I thought there was 3. Maybe it was like 3 separate accession numbers. And we all looked, and it's like this subepidermal vesicular dermatitis. There's tons of neutrophils. And then we looked in these vesicles, and there's like these weird little cells that we didn't know what they were. They were like, had these kind of hyperchromatic borders. And we're like, those are organisms. We don't know what they were. And the patient was just looking worse and worse. And we're like, what infection does he have? So we did all of these special stains. And we thought, oh, they look kind of like cryptococcus, and all the special stains were negative. All of our studies were negative. We didn't know what was going on. So we like sent the slides off to hematopathology. We sent them to a GI pathologist who had been with the CDC for years. And we were like, what organisms are these, right? And, you know, we just get back, it's not a heme malignancy. It's not a GI process, but nobody knows what it is. And all of us dermatopathologists, we don't know what it is. So we then, I think, I don't know who it was. One of the residents sent pictures around the department. And of course, it's the non-dermatopathologist that was like, oh, that's what the path looks like. Well, it must be cryptococcoid sweets. So for us, like, even no matter how much I would love to be the one that came up with that correct answer, and I want to be the smart one, like, to me, this is a victory. Like, it was Dr. Madigan who just is amazing and just has this brain full of knowledge, but she had read about, you know, a pathology report that looked like cryptococcus, and she was able to put it together. But with that knowledge and asking friends for help, we were able to arrive at the correct diagnosis. So I think that's something we do a lot as dermatopathologists. Like, it's okay to ask for help, and it's okay to say you don't know what's going on. And sometimes that's how we'll get the patient what they need. So kind of ending on, I just want everybody to remember to trust your gut. If you biopsy a lesion that looks like this and you get a histologic diagnosis that's a seborrheic keratosis, that doesn't make any sense, right? It's okay to question your pathology report. Please call us. Please say, you know what, that doesn't make any sense. You need to pull the slides. You need to make sure the tissue matches. And just remember that everyone makes mistakes. We're a team, and what we want is the best answer for the patient, even if it means we're wrong. And then just a couple things like that you can do in clinic to make our lives easier and maybe get quicker answers. We really do look at the pictures that you guys take in clinic. So we love pictures. If you're biopsying neoplasms, if you could try to like keep your ink off the neoplasm, it's very lovely to be able to see them ourselves. And having like a history of a rash included in a note can help us think about other differential diagnoses, including descriptions. Yeah, coming up with your own differential, I think, is key. I think that sometimes in a busy clinic, it can be easy to be like, I don't know what's going on. I'm just going to biopsy it and hope that helps me. But having that differential before you biopsy is really crucial to performing the correct biopsy in the correct location. And then just remembering to question your results if stuff doesn't make sense.
Take pictures of your rashes too.
Oh yeah, take pictures of everything and like be really easy with your ink. Does anybody have anything that they would like to add?
We have a couple comments in the chat from
Okay.
Pat. The first one is, it's also super helpful to have a clinical description of lesions, not just the clinician's differential diagnosis, especially for pigmented lesions. If we do not have access to a clinical photo, the size and description of irregular coloring can be very helpful. A punch from an MIS could be interpreted as a nevus otherwise. And then a second,
Knowing whether something's, I think getting the heart of it, like knowing whether something's a partial sampling or a full sampling is helpful. Being like, I removed this neoplasm versus I sampled this neoplasm is helpful to know.
And then another one from her, also with alopecia biopsy, try to orient punch not perpendicular to scalp, but so the hairs and depth of punch will be parallel. It will capture more follicles. Like punch may be oriented more like a leaning tower of Pisa.
So does everybody understand that? Just kind of like look the way the direction the follicles are going in the scalp. Don't necessarily just go perpendicular to the skin surface. Follow those follicles path. Good? Okay, we can move on to patients.
Yeah, exactly. Yeah, so just teach me, just hit the.
It's actually good already, just don't hit it again.
Thanks, Dr. Zussman. Appreciate that. Oh.
Start with the differential. Easy job.
It's all good. Hello, everyone. Nice to meet you, new residents. Name is Dave. We're going to do a patient from Dr. Rhodes. Fun fact about me, if you don't know, I love Baby Yoda. He brings me so much joy in life, so I always have my Baby Yoda pins on. So this is a 25-year-old female. Some of you guys saw her in clinic today, but she has a history of eczema, and she's presenting with complaints of hair loss. So her hair loss includes hair thinning, shedding, breakage of the hair, and loss of hair on the scalp, eyebrows, eyelashes, axilla, arms, and legs. She also has sparse genital hair. This has been occurring for about 8 years now, and she's been continuously flaring for the past like 4 years. And so she's only treated with over-the-counter products with no improvement. She's never had any biopsies before. And she also notices incidentally that she has kind of red bumps everywhere on her body and at the sites of hair follicles. So, and her past medical history is important for anxiety, depression, GERD, and NASH. Some medications that she's on rixatriptan, loperamide, meclizine, pantoprazole, and a Kylena IUD. She has no history of iron deficiency, extreme weight loss, medical illness, or thyroid disease. And she has no family history of hair loss or balding. So for those of you who saw her in clinic today, you can see kind of on the vertex, my mouse maybe is on the vertex of the scalp and frontal scalp, there's diffuse hair thinning with some perifollicular erythema, and there's hyperkeratosis with yellow to white scale as well. That may not be seen as well in the photos. On the face, neck, chest, back, arms, and legs, there's this widespread eruption of skin-colored to pink-red papules with perifollicular erythema and accentuation. There's absence of axillary hair, and the patient has sparse pubic hair, sparse hair on the arms and leg hair, and there's also thinning of the eyebrows. This is where one of the biopsies was done on the neck, but you can see kind of that skin-colored to pink-red papules with some perifollicular erythema. And so for those of you who saw her today or based on the photos, I'd love a clinical differential from the group, or if anyone has any thoughts. So we have LPP that has been mentioned. Ichthyosis has been mentioned as well. Right? Rhinoderma has been mentioned as well. Keratosis pilaris. Okay. Graham-Little-Picard-Lesueur syndrome. I probably pronounced it very wrong, but that's what Dr. Bertosh mentioned. Anything else? Okay, so
Luke said
oh.
hypothyroidism.
He has no history of thyroid disease, and I think TSH was checked, correct? Okay. So let me exit out here and just pull up so I can type in the extra differentials. Oh, sorry. I'm not very good with Macs, guys. I'm a PC guy. So these were some of the differentials that have been mentioned. Also, keratosis follicularis spinulosa decalvans, which is actually it's an inherited rare follicular disorder. That's something as well that can be added. Yeah, I can type it. Do whatever you want. Yeah. What do you want to say? I for sure spelled that wrong, but yeah, I think it's PHRY. But yeah, okay. I think I still spelled it wrong. That's cool. And then what else was that? You already talked about carrot. Yeah. Max, that tell you. All right. So let's go back here, and let's go. And I think Meredith is going to go over the pathology. Yeah.
Perfect. All right, let's start with the left forearm here, seen at magnification 4x. Perfect. And then go to the next slide. And as we get closer, we begin to appreciate this follicular plugging with inflammatory debris kind of in the infundibulum. Going to our next biopsy, this is the second biopsy, and it's from the posterior neck, seen here at 4x. And then if we go to 10x, we'll begin to appreciate some perifollicular fibrosis with scattered lymphocytes. And then the third and final biopsy is a punch from the anterior vertex scalp, starting here at 2x, and then our next slide is increasing to 4x, and we see a lymphocytic predominant inflammation with focal follicular destruction. And we have another slide at 10x also showing that. So the line diagnoses for this, for the left forearm, follicular plugging and suppurative folliculitis, the posterior neck, focal perifollicular fibrosis and lymphocytes, and the anterior vertex scalp, lymphocyte predominant scarring alopecia with focal follicular destruction. So with that now pathological add, anything else that you would like to take or add to the differential diagnosis?
All right, so thank you, Meredith. So Dr. Rhodes, when she referred this patient, we'd love if we could get a unifying diagnosis from the group, and then further recommendations on, I guess that'll be based on kind of what our diagnosis is for treatment management. And so, yeah. Any thoughts from the group on a unifying diagnosis for this patient? I feel like it's one of the maybe, Graham-Little or keratosis follicularis spinulosa decalvans, but here, Dr. Roses.
I mean, just to give a little bit more history, I mean, she's 25 and she says that what's going on in her scalp has been there for at least 8 years. And she said that as far back as she can remember, all the hair follicles on her body have looked like that and been really red. And so I thought it was more than just KP on her body, because she definitely has a reduced follicular density, and she certainly has less axillary hair and pubic hair than she should. So, I mean, I considered Graham-Little. It's weird, though, that she doesn't have that kind of LP appearance in the pubic area, because I thought it was just scalp and pubic area LPP. And so I didn't know if that would explain everything else that was on her body. And I thought about the keratosis follicularis spinulosa decalvans. Did I get that right? But I've never seen that before. And when you read about it, it sounds like it sort of burns itself out before her point in life. I was hoping one of the peds people might be here. Maybe if they have any ideas and they're online, could email me as to whether or not they think that could be consistent with this. Kind of what I was thinking from a treatment standpoint is if we don't really have a good answer, is that I would treat her as if she had LPP simply on her scalp and see how that goes. But if this is a genetic condition like the KPSD, that I don't know that she's going to respond all that well.
Luke said, I think females with KFSD can have funny mosaic presentations thanks to lionization. I guess you could do genetic testing.
Oh, there's genetic testing for it. Okay, that's great.
I was reading last night and I couldn't find genetic testing. So if there is, that would be awesome.
Just said he thinks there's genetic testing for it. KFSD.
Follicularis spinulosa decalvans. It's like in one of those Bologna tables that we like glance over because it's like just like a little chart there with a bunch of disorders like IFAP and all those disorders that we don't really think we ever see. So I guess.
This would be a really good one to bring back if there's an answer. Yes, if there's a genetic test that does say, yay.
Does she have any kids, Dr. Rhodes, or any suggestive family history? Not that we are aware of, Dr. Johnson. Her dad may have sparse eyebrows.
I was reading about Graham Little. Does most of the scarring is just on the scalp with the alopecia, more LPP-like, and then in the genital scarring type of alopecia, and then
Oh, Dr. Bertosh was saying on his review, Graham Little Picard, it tends to be a non-scarring alopecia in the axillary and the pubic region. They tend to have a lichenoid eruption on the trunk with perifollicular erythema. And then I think you mentioned something else.
non-scarring.
Yeah, yeah, it's non-scarring in the axillary and pubic region, and then scarring on the scalp. Pretty cool case, Dr. Rhodes. Anything else from the group? Okay, well, thanks to everyone. Thanks, Dr. Zussman. Nice to meet you, new resident. Thanks, Chloe, for the cow, and have a great day.